Hello, my name is Ethan Hartman. Welcome to my talk on Seizure as an Initial Presentation. Welcome to my talk on Seizure as an Initial Presentation for Posterior Reversible Leukoencephalopathy Syndrome in Lupus Nephritis. Posterior reversible leukoencephalopathy syndrome, also known as reversible posterior leukoencephalopathy syndrome, is a condition presenting with neurological manifestations including seizures, headaches, and focal neurologic signs. The syndrome often mimics neurological conditions such as stroke, intracerebral hemorrhage, encephalitis, or meningitis, all of which should be kept on the differential. PRES may also mimic neuropsychiatric conditions such as neuropsychiatric lupus. It is typically associated with an increased rise in blood pressure, metabolic abnormalities, and altered sensorium. Risk factors include female sex, pregnancy, uncontrolled hypertension, organ transplant, immunosuppression, kidney disease, and inflammatory conditions such as lupus. In this poster, we present an initial presentation of PRES syndrome secondary to uncontrolled hypertension in the setting of undiagnosed lupus with lupus nephritis. A 21-year-old female with history of hypertension, cocaine, and marijuana use presented to the hospital with new onset unremitting seizures. 2 weeks prior, she had developed a rash on her face and arms after excessive sun exposure and had complained of pain in multiple joints in the same time period. She was previously prescribed amlodipine and hydrochlorothiazide, but both medications were recently discontinued for unknown reasons. She was scheduled to see her primary care provider, who was going to send diagnostic tests for lupus, but was unable to. Vital signs on arrival to the hospital included a blood pressure concerning for 200 over 108 millimeters of mercury, with the rest of the vital signs within normal limits. On examination, she was noted to have a rash and a butterfly distribution over the face, oral ulcerations, and lesions covering the dorsal aspects of both forearms. Initial labs demonstrated normocytic anemia, acute kidney injury, and hyperkalemia. ANA and double-stranded DNA were both positive, and C3, C4 complement factors were found to be significantly decreased. Brain MRI demonstrated patchy cortical and subcortical edema in the posterior lobes. The combination of clinical presentation, laboratory markers, and imaging suggested PRES syndrome in the setting of systemic lupus erythematosus. The patient was treated with intravenous lorazepam and labetalol to control the seizure and blood pressure respectively. Once stabilized, the patient was admitted to the hospital for further workup and treatment. The patient was started on methylprednisolone pulse therapy, which provided improvement in arthralgias and helped to resolve the acute kidney injury. The patient was transitioned to mycophenolate mofetil and a prednisone taper before being sent home with instructions for follow-up. In Figure 1, you can see the fluid-attenuated inversion recovery MRI of the brain revealing cortical and subcortical edema. Figure 1a demonstrates a parietal distribution of edema, while B and C demonstrate edema in the temporal and occipital lobes respectively. Figure 2 is an example of the histological appearance of stage 5 lupus glomerulonephritis. Note that the glomerulus has extensive subepithelial accumulation of immune deposits with spike formations characteristic of stage 5 lupus nephritis, which is also similar in appearance to membranous nephropathy. In summary, we demonstrate a case of PRES syndrome, which is important to include on a differential diagnosis in a seizing patient. This case report demonstrates a patient with multiple precipitating factors, including high blood pressure, drug use, and autoimmune disease. These conditions are important to screen for in the clinical setting, even in young patients such as this one. It is likely that this condition could have been prevented given adequate control of these conditions with medication and lifestyle adjustments. Ultimately, patients like this one should be counseled on appropriate use of blood pressure medications, avoidance of drugs that may raise the blood pressure, and control of autoimmune disease with steroids and immunomodulators. Thank you for your time. Have a nice day.